And we're back. So we're going to pick up the discussion with essential fatty acids and cardiovascular disease. But before we do, I just want to make the point that if you haven't done it, you should really go and get your own blood work done and look at your own cardiovascular risk profile according to the numbers, and then see where your strengths and weaknesses are. And then from there, apply aggressive dietary and lifestyle practices and even use supplements if necessary. And 3 months later, go back and have your blood work done again. And I think you'll be quite surprised at the impact that diet and lifestyle have on improving those numbers. Watching your body respond to the effort that you make is quite incredible. And most people are walking around in this world without really having a true appreciation for how much of a change these diet and lifestyle factors can have on influencing their actual values around cholesterol and triglycerides and blood pressure and all these other things, fasting glucose levels and hemoglobin A1C, fructosamine. You can have a profound effect on these things, unless you've got some major genetic impediment to being able to affect it. But most people can have a very significant impact on these numbers. And when patients see those numbers changing through their own efforts, not just by taking drugs, but through their own proactive measurements and efforts, it really empowers them to keep going. And that's why I don't really like to do nutrition consultations with patients unless I have their lab values in front of me, and we can actually put some hard markers down as to what the goals are in terms of where we want this blood work to get to through their efforts and my guidance. And that really creates a therapeutic bond that empowers the patient. When they see changes, it truly motivates them to keep going. All right, what about essential fatty acids? Well, it's no surprise that fish and fish oil and omega-3 fats help to reduce risk of cardiovascular disease. So you already know that when you ingest fish and fish oil, that those omega-3 fats, eicosapentaenoic acid in particular, becoming part of the phospholipid, esterifying the phospholipids in the cell membrane, that the phospholipase enzyme can release that EPA or eicosapentaenoic acid, and the EPA can move down a series of biochemical steps and to form prostaglandin series 3, which will then dilate blood vessels. And in platelets, it'll form certain prostacyclins that decrease the stickiness of platelets. And also the prostaglandin series 3 that reduces inflammation in the blood vessel wall. All of these factors are very well documented effects of omega-3 fats, may even help to reduce cholesterol to some degree, possibly by making the fluidity of the cell membranes improved. And when you improve the fluidity of the cell membrane, even LDL receptors, LDL receptors will work better so they can clear more cholesterol from the bloodstream. We think that might be one of the ways. As opposed to arachidonic acid that you get from eating a lot of high-fat meat products. So arachidonic acid is really the nemesis of omega-3 fats. When it gets pulled off the phospholipid structure by phospholipase A2, it becomes prostaglandin series 2 eicosanoids, which cause blood vessel constriction and increase the platelet stickiness. Arachidonic acid gets converted to thromboxane A2 in platelets, which makes platelets very sticky. So this is the other way that eating a lot of meat and pork increases cardiovascular disease problems. Not just that it raises saturated cholesterol levels, but it also makes the platelets stickier, and it makes blood vessels constrict to a greater degree, increasing risk of high blood pressure, peripheral resistance, denuding of the endothelial cells, all of that. So of course the recommendation is to have 2 fish servings per week, but not more than that, because the Environmental Protection Agency says if you have more than that, if you have more than 2 servings of fish a week, you start to run the risk of mercury toxicity. and there's just no way to know how much mercury you're getting from different fish. So you try to eat ones where you know the mercury content is lower, but even then, 2 servings per week maximum. So this is where supplementation with essential fatty acids, I think, is critical, because we have such an imbalance in our system, for the most part, of omega-6 to omega-3, that you want to try to lower the arachidonic acid concentrations in your cell membrane and try to raise the omega-3 ones so you can make a healthier and more health-promoting prostaglandins series 1 and series 3. So in my view, the best way to do that is to take an essential oil supplement each day that has fish oil with flaxseed oil and borage seed oil. And that's why a number of manufacturers make that combination. You'll find that in the marketplace under different brand names. And the reason that's so popular is because of the biochemical steps that we'll look at here. So here's icosapentaenoic acid from fish and fish oil, and in just one step, using cyclooxygenase or lipoxygenase, it becomes prostaglandin series 3, and also these anti-inflammatory leukotrienes. So this dilates blood vessels, it makes the platelets less sticky, it reduces blood vessel inflammation. All very positive things. And remember that fish oil also contains docosahexaenoic acid, DHA, and EPA can become DHA, and DHA can become EPA depending on how the body requires it. DHA is a very important part of the nerve cell membrane phospholipids, especially in the brain. But remember that alpha-linolenic acid, which is an omega-3 fat found in a lot of plant foods, and very high in flaxseed oil, about 57% or 58% of all the essential fats in flaxseed oil are alpha-linolenic acid and omega-3 fat, that the body can slowly elongate and further desaturate that down to icosapentaenoic acid using these enzymes delta-6 and elongase and delta-5 desaturase. But from one person to the next, there's a lot of polymorphism in these enzymes. So maybe my body can do this really efficiently, but someone else's body, can't make that conversion very well. So from one person to the next, the speed at which you're going to convert alpha-linolenic acid to EPA varies quite significantly across the population. So it's very hard to know, how well your body's doing it. But the nice thing about this conversion from alpha-linolenic acid to icosapentaenoic acid is that it's using the same enzymes that convert linoleic acid into arachidonic acid. And so by slowing down this process, you end up with less arachidonic acid in your cell membrane. And by eating less meat products, you end up with less arachidonic acid in your cell membrane. So when there is arachidonic acid there, the enzyme that converts it, cyclooxygenase and lipase, it's the same enzyme that converts EPA into these prostaglandins, converts arachidonic acid into these prostaglandins. And these prostaglandins are prostaglandin series 2, which cause vasoconstriction, they cause inflammation, and they cause platelet stickiness. And so what you want is more prostaglandin series 3 to be produced and less prostaglandin series 2. The way that you do that is by having more higher tissue concentrations or cell membrane concentrations of EPA and less of arachidonic acid. You're going to have less arachidonic acid if you eat fewer meat products, and if you have alpha-linolenic acid from flaxseed oil driving this pathway and slowing down this pathway. And the other thing is that prostaglandin series 1 also reduces inflammation in the body. It's considered to be a pretty healthy prostaglandin. And you make that from dihomogamma-linolenic acid. It says gamma-linoleic here, but that should say gamma-linolenic. And it's really gamma-linolenic becomes dihomogamma-linolenic, and that becomes prostaglandin series 1. So borage seed oil is very rich in gamma-linolenic acid, and that is the reason why it's included in these combination essential fatty acid capsules to try to help the body make more prostaglandin series 1, which it will do if there's vitamin C and vitamin E and magnesium and B6, all helping to drive this pathway. So we'll take it to the next level. Remember too that omega-3 fats also inhibit tumor necrosis factor alpha and interleukin-1. These are very inflammatory cytokines and drivers of inflammation. Omega-3 fats also help to inhibit these pro-inflammatory cytokines. This is another way that it reduces inflammation, including inflammation in the blood vessel wall. So just to look at this again, arachidonic acid, if it's esterifying the phospholipid structures, phospholipase A2 will release that, and using cyclooxygenase, it can become thromboxane A2 in platelets, which makes the platelets clump together, and it's a greater chance you're going to have a thrombus or a thromboembolism forming when your platelets are sticky. And also different prostaglandin series 2 intermediates produce inflammation and cause a blood vessel constriction. And you can also form a lot of inflammation through lipoxygenase enzyme down through to produce leukotriene B4, which occurs in many white blood cells like macrophages, let's say, as an example. So of course drugs like aspirin and ibuprofen and indomethacin, Voltaren, diclofenac, they block cyclooxygenase. And in doing so, they decrease the stickiness of platelets by inhibiting thromboxane A2, so that's how they make your platelets less sticky. But if they make the platelets too unsticky, then of course you can have a hemorrhage inside your body. If the platelets can't clot when they need to, you can end up having a hemorrhagic stroke. So getting that balance right when you start giving people drugs becomes very tricky coordination exercise. Okay, so this takes us now to bioenergetics and the aging heart. So now we're going to talk about energy production in the heart muscle itself and the importance of this and its relationship especially to congestive heart failure in our society. So just so you're aware of this, after the age of 65, the leading cause of hospital admissions is congestive heart failure. There's been a significant increase in the incidence of congestive heart failure in the last 2 or 3 decades for a number of reasons, and we'll look at some of these. But in the aging process itself, coenzyme Q10 plays a big factor. So CoQ10 is also known as ubiquinone. The body makes coenzyme Q10. I'm going to show you how the body makes it. But CoQ10 is a vitamin-like substance that's found in all the cells of the body, and it looks a lot like vitamin K. And so I'll just bring this to your attention early, that if a person is on Coumadin or warfarin, which is blocking the effects of vitamin K on the production of clotting factors, so those drugs are trying to thin the blood, in very rare circumstances, but it has occurred in case reports in humans, CoQ10 supplementation can sort of step in and act like vitamin K and perform these carboxylation reactions that allow these clotting factors to be made, sort of antagonizing the effect of the drug and lowering the INR, making the blood stickier than what the doctor wants it to be. So if you're giving coenzyme Q10 to somebody who's on Coumadin or warfarin, then the INR needs to be monitored very carefully in the first few weeks to make sure that CoQ10 is not countering the effect of the drug. That has to be an exam question right there. But in the normal physiological course of events in the body, the thing that CoQ10 is doing so magnificently well is it acts as an electron acceptor and electron donator in the mitochondrial cytochrome chain. So between cytochromes 1, 2, and 3, it's picking up the hydrogen electron and it's passing it down the chain. And as it passes it down the chain, energy is released, and that energy is used to recouple inorganic phosphate with ADP to form ATP. So the cell has ATP energy, which is the energy source that cells need to function. So as we're going to see, as we get older, CoQ10 synthesis declines as part of the aging process. And in doing so, it's like there's a piston missing in the engine in the mitochondria. You make less ATP. There's like a power shortage that starts to occur in the cells of the body. So here's what CoQ10 looks like. It resembles to a significant degree the chemical structure of vitamin K. So as I said, CoQ10 is a vitamin-like substance present in all human cells, and it's responsible for the production of the body's own energy. 95% of all the ATP energy that's being generated by the body when you're at rest or during light activity or just sitting watching your computer now or looking at your tablet, looking at your phone and watching this presentation, 95% of all the energy in your body that's being generated is using oxidative phosphorylation in the mitochondria. It's aerobic energy that you're producing to get 95% of your energy. And for that energy, you need CoQ10 to be shuttling the hydrogen electrons down the cytochrome chain in the mitochondria. So as the CoQ10 synthesis declines, the organs that have the highest energy requirement are the ones to really feel the effects of that in a negative way, such as the heart muscle, the lungs, and the liver. These are where you see the highest concentrations of CoQ10 in the body. So once again, you see that CoQ10, if you look at the mitochondria and the cytochrome chain, it's shuttling electrons between complex 1 and then to complex 3 so that energy can be released, and that energy then is going to recouple ADP with inorganic phosphate to make ATP, so you have energy production coming from that part of the mitochondria. If CoQ10 declines, it's like there's a piston missing in the engine. You can't make as much ATP energy, and so the tissue has less access to ATP energy. It can't perform at an optimal state of function. So here you actually see the reported decline in CoQ10 in different tissues as we get older. So you see starting at age 20, there's a decline in CoQ10 synthesis, and look at how that decline affects the myocardium, the heart muscle. By the time you get older, it's a significant decline, where you're down to less than like 43% of what it once was. So even by the time you're 40 or 45 or 50 years old, this is the time we think you should be putting CoQ10 back into your body to try to maintain your levels at something that is more youthful, so you don't run into congestive heart failure and high blood pressure problems and even other problems. But you also see a decline in the kidney and the lungs of CoQ10, and also decline in the liver to some degree. So here you just look at the decline in CoQ10 in the heart muscle itself. Again, after age 20 or 21, the decline begins, and as you get to middle age, once you're in your 40, 45 years old, this is when the decline is actually a significant amount of decline, and then it just gets worse from there. So people not supplementing with CoQ10 after the age of 40 or 45, I don't really understand why they wouldn't do that, to be honest with you. So a CoQ10 deficiency is associated with a number of health conditions. First of all, congestive heart failure. As I said, it's the leading cause of hospital admissions in people over the age of 65. And congestive heart failure doesn't just occur because the person runs out of CoQ10. That'd be an oversimplification. You can also, due to high blood pressure, be straining the heart muscle repeatedly, creating this ventricular hypertrophy and straining the muscles, and so they get weaker over time. And also, if you have a lot of advanced atherosclerosis in the coronary vessels and there's less oxygen available to the heart muscle, it's going to be straining as well to generate energy. It can't pump as much, it can't make ATP because there's less oxygen getting there. So CoQ10 decline is not the only contributing factor, but it is a key factor. And I have seen on many occasions now people who have a declining ejection fraction, congestive heart failure is developing. It's at a certain stage, even more advanced stages, when they start taking coenzyme Q10, that it starts to bring the heart muscle pump back to perform at a much better ejection fraction rate. And they feel better, their quality of life is better. Sometimes they go back to work and they have a reasonably normal life. There's been some case histories that I have seen personally that are just astonishing. So the CoQ10 deficiency is also linked to high blood pressure to some degree, because CoQ10 is required, as are other nutrients like folic acid and so on, to make nitric oxide in the endothelial cells that line the blood vessel wall. And as you make nitric oxide, it dilates the blood vessels to allow the appropriate amount of oxygen and blood flow to the tissues, including the heart muscle itself. So when you have less CoQ10, less nitric oxide gets released, and so you have more vasoconstriction. It creates decreased, more peripheral resistance, so the diastolic pressure goes up. Then the heart has to work harder to pump blood through that, across that resistance, so now the systolic pressure goes higher. So I've seen CoQ10 supplementation, and this is well documented. It can help to lower blood pressure in many cases as well. And deficiency of CoQ10 also seems to aggravate stable angina and arrhythmia problems. So it has application in these conditions. So there's stable angina, and then there's unstable angina. So stable angina is the person is under resting conditions, doesn't have any angina pain. But they get on a treadmill and they start walking, the treadmill goes a little faster and a little faster. And at a certain threshold point, the oxygen to the myocardium is not getting there efficiently, so they start to get some chest pain. And that's called stable angina. Unstable angina is the angina that can strike at any time. I'm just sitting in a chair and I start getting chest pain. That's unstable angina. And CoQ10 has not been shown to be that valuable for unstable angina. But for stable angina, it's been shown to help improve it as part of the complementary management, and it's been shown to help in certain cases of arrhythmias as well. As we're going to see, CoQ10 also is required for normal immune system function, and we know that one of the first events in Parkinson's disease is a decline in coenzyme Q10 synthesis in the substantia nigra in the midbrain. And from there, then you can't make a lot of the complex 1 to 3 in the mitochondria starts to fail. Less energy is produced. You can't make the dopamine required, so dopamine synthesis drops off. You get tremors, and then you have the electrons leaking out of the mitochondrial chain, generating all kinds of free radicals that eventually kill those particular nerve cells in that part of the brain. So a decline in CoQ10 is strongly linked to the Parkinson's disease pathophysiology. And we've seen in the courses on nutritional medicine and neurology the importance of CoQ10 to Parkinson's patients, especially if you can get it to them in the early stage of the disease. So here's how the body actually makes coenzyme Q10. It from acetyl coenzyme A, which all the cells have, down this long pathway and then across, it makes ubiquinone. The other name for CoQ10 is ubiquinone. And from tyrosine and phenylalanine, this is a secondary pathway through which the body can make some CoQ10, but this is the primary pathway, down from acetyl coenzyme A to form ubiquinone here. Now notice that this is also the pathway through which the body makes cholesterol. So when a person has high cholesterol and a doctor prescribes a statin drug, Lipitor, Crestor, one of these statin drugs, it's blocking the HMG-CoA reductase enzyme right here. So it's blocking the synthesis of cholesterol. And when it does that, it's also blocking the synthesis of coenzyme Q10. There are studies that show that since the introduction of statin drugs, that the incidence of congestive heart failure has increased quite markedly. And we think it might be a side effect from the statin drug. Doctors are supposed to tell patients, if they're giving them a CoQ10, giving them a statin drug medication, to take coenzyme Q10 at least 90 to 100 milligrams a day, so they can get the CoQ10 that they need to maintain the energetics within the heart muscle itself, so the congestive heart failure doesn't develop. But oftentimes that doesn't get passed along to the patient. Sometimes the pharmacist will actually tell the patient this and sort of catch it at the time that the drug is being dispensed. But the point I want to make here as well is that when you give somebody a statin drug to block the synthesis of cholesterol, so you're blocking a normal event in the body. Let's say I ate food that has a lot of saturated fat or trans fats, and they go to the liver through the chylomicron, and now the liver needs to get those fats out of the liver, otherwise you're going to develop fatty liver degeneration. So the liver's trying to make the very low density lipoprotein to package those triglycerides into that lipoprotein, and then it wants to excrete it and ship those fats over to the fat cells, so the fat cells will store the fat, or to the muscle cells, so muscle cells will burn the fat. But in order to make the very low density lipoprotein, you have to turn on cholesterol synthesis from acetyl coenzyme A. So when you block that process, you block the ability of the liver to make very low density lipoproteins the way it normally would. And so a lot of fat starts to get trapped in the liver cells. Like, you start to decrease the ability of the liver to secrete the very low density lipoprotein and transport that fat over to the fat cells. So while you're lowering then the LDL cholesterol, because you have fewer VLDLs and now there's going to be fewer LDLs as remnant particles, so the LDL is going down and the total cholesterol in the bloodstream is going down. So the drug's accomplishing that purpose, but it's trapping fat inside the liver cells. And that's why doctors have to look at liver enzymes in the blood to see if liver cells are being damaged in this way. Because if fatty liver degeneration occurs, which is also known as non-alcoholic steatohepatitis, which can lead to liver fibrosis and then to cirrhosis, you can have permanent and life-threatening liver problems if too much fat builds up in the liver. So this is why where there's not a genetic problem or the person's not in some super high risk category, the first line of defense to lower blood cholesterol really should be diet and lifestyle practices. The drug should not be the first intervention. And in all the pharmacology books, it really tells health practitioners that that is the first approach they should use. But what typically happens is a statin drug gets recommended and it blocks this process. Cholesterol in the blood goes down, but you're also blocking CoQ10 synthesis. You're trapping fat inside the liver, and you're producing other side effects because these drugs are also blocking cholesterol synthesis in the brain, which then is linked to memory loss, and other problems occur. So diet and lifestyle should be the primary focus of this kind of management, unless the person's in a very high-risk situation. Let's say they've already had a heart attack or a stroke, or they've got some major genetic blocks. They don't make LDL receptors, or they have other genetic problems that are causing the high cholesterol where diet and lifestyle can't actually get it into the ideal range. So here we see a classic example. Here's an individual at age 70-year-old female who goes on, whose ejection fraction is already down at 50%. Then she goes on a statin drug, which the statin drug lowers her coenzyme Q10 because the CoQ10 synthesis is decreased. So now her ejection fraction drops much further because she no longer can produce the ATP energy in the heart muscle. So now she's developing congestive heart failure in a significant way while they're trying to lower her cholesterol. She goes off the statin drug and the CoQ10 synthesis starts to increase again and her ejection fraction comes back. This is not an uncommon scenario in our world today. So the thinking is that just for general prevention, just looking at the aging process, that a lot of health experts, and I would agree with this, around age 40 or 45, you probably should start encouraging people to take about 30 milligrams a day of coenzyme Q10 to make the CoQ10 their body's not making for itself. And remember that it's fat soluble, so it needs to have some fat in the stomach to absorb that supplement. And then by age 60, because there'd be a further decline in CoQ10 synthesis, you might want to take 60 milligrams a day or possibly even more than that. And so is there CoQ10 found in food? There is some CoQ10 found in food. And on average, people get about 5 to 10 milligrams of CoQ10 a day from food, which is fine up till about age 40. But then after that, in order to get the 30 milligrams that you're shooting for, you'd have to eat half a pound of sardines or 2.5 pounds of peanuts every day to get that CoQ10. So it's just not practical to get it from food after the age of 40 as the primary source to compensate for the amount your body no longer makes. So CoQ10 would be classified then as what's called a conditionally essential nutrient, whereby when you're younger you have enough as a rule, but then as you get older the decline in synthesis requires that if you want to maintain optimal function you need to supplement it. So it's a conditionally essential nutrient. These are the other features of CoQ10 that are important. It's a fat soluble antioxidant. So once again, you need fat in your stomach to absorb it, But then the CoQ10 works in your body in the fat-soluble tissues. So first of all, it actually gets carried by the lipoproteins, by chylomicrons, by the very low-density lipoprotein, by the IDL, by the LDL, ultimately delivers it to the tissues of the body. And inside the lipoproteins, it acts as an antioxidant to protect LDL from oxidation, helping to decrease atherosclerosis. And the atherogenic properties of the LDL are less if it's not modified or oxidized by free radicals, as we've spoken about. But then once in the tissues, it works around the cell membrane, and including the mitochondrial membrane, where it helps to mop up a lot of free radicals, where electrons are leaking out of the electron transfer chain. As soon as the free radicals form, it can help to quench that before you get extensive damage to the mitochondrial DNA or to other parts of the cell. And also in the brain, CoQ10 is a very important fat-soluble antioxidant. The brain is a very fatty, waxy tissue, and these fat-soluble antioxidants are very important in the brain to prevent oxidative damage to brain tissue. And also in the mitochondria itself, of course, it's acting to transfer hydrogen electrons down the cytochrome chain to make ATP energy, but at the same time it's acting as an exquisite antioxidant in that area of the cell. And the other antioxidant that works with it in that area of the mitochondrial membrane is alpha lipoic acid, which is another conditionally essential nutrient, because it also declines as we get older. And alpha lipoic acid, remember, is both a fat-soluble and water-soluble antioxidant. CoQ10 also enhances immune system function, and it has tumor suppressive properties. In other words, experimentally, we see that CoQ10 can enhance the tumor killing effect of certain immune cells in the body. So as we get older, as we lose that CoQ10, we think it also causes compromised function of the immune system to some degree, and less of an ability of some of our immune cells to actually identify cancer cells and to kill them. So CoQ10 and congestive heart failure. So we see from myocardial biopsy studies that in 50 to 75% of patients that have a congestive heart failure, that we see a coenzyme Q10 deficiency. And I will tell you that studies show in most cases that if you give those people the CoQ10 back that they're missing, that the ejection fraction in the heart starts to get stronger. The heart pump gets stronger, unless there's advanced coronary artery disease or some other situation. But CoQ10 usually can help to bring back the ejection fraction. I've seen people who are in serious states of dilated cardiomyopathies and advanced congestive heart failure use CoQ10, and they have responded magnificently well. It's not going to work for everybody, but it's certainly something that should be implemented on a regular basis, according to a lot of experts, and I would agree with that. So you want a low blood level of CoQ10 would be something below 3.5 micrograms per milliliter. So if you're giving CoQ10 to somebody who has congestive heart failure, and you want to track their blood level to see, when you're getting it into the ideal range, tracking their CoQ10 blood level is a good idea if there's a lab that can do it. Not all labs do this. The therapeutic dose for congestive heart failure is usually 150 to 300 milligrams a day in total. Usually give the person 50 to 100 milligrams 3 times a day with food that has some fat to help get the absorption across. And if you haven't used this product before, you'll be shocked at what a difference it can make for a large number of people. So unfortunately, CoQ10 is not commonly prescribed by North American doctors on a regular basis, but it is prescribed regularly for congestive heart failure and other conditions in Denmark, Italy, Sweden, Israel, and Japan. There's no major drug-nutrient interactions. In fact, people using CoQ10, often their heart medications can be reduced over time by their doctor because their heart performance improves. But of course, there is this potential interaction between CoQ10 and warfarin and Coumadin, simply because CoQ10 has a similar structure to vitamin K. So sometimes it can actually compensate and behave like vitamin K, producing clotting factors when you're actually trying to inhibit the formation of clotting factors by giving Coumadin and warfarin. So the INR needs to be monitored in patients when you're giving them CoQ10 if they're on Coumadin or warfarin. CoQ10 supplementation in other cardiovascular disease problems. So in high blood pressure or hypertension, the typical dose would be 100 to 200 milligrams a day. And what you're doing here is you're trying to increase the nitric oxide from the endothelial cells that line the blood vessels so they can dilate the blood vessel, decrease peripheral resistance, and then the heart doesn't have to work as hard, so the systolic pressure comes down. And that's how CoQ10 can help to lower blood pressure, as it's been shown to do in a number of clinical studies. And in stable angina, the typical dose is 100 to 200 milligrams a day, trying to help the heart muscle generate more ATP energy in the presence of the oxygen that's available for it to have. And when it's making that ATP energy, it's not struggling as much, and so the angina isn't triggered to the same degree. And also, in certain arrhythmias, some doctors will recommend 100 to 200 milligrams a day, but normally it would be along with other agents that we're going to look at very soon: L-taurine, L-carnitine, D-ribose, and hawthorn. And hawthorn is also a great one to help lower blood pressure as well. I like giving CoQ10 with hawthorn. We'll talk about hawthorn shortly. And then patients who are already on statin drugs, regardless of their age, and who don't have congestive heart failure yet, even if they don't have high blood pressure, just to guard against the CoQ10, coenzyme Q10 deficiency, they should be given at least 90 to 100 milligrams a day of CoQ10 to prevent problems from developing related to that CoQ10 deficiency. And I'm going to bring your attention to this fellow, Dr. Stephen Sinatra, who's a very famous cardiologist in the United States. He's written a number of books, including The Sinatra Solution, Metabolic Cardiology. He's a cardiologist who uses nutrition and supplementation to manage a whole host of different cardiovascular problems, including cardiomyopathies and atrial fibrillation. And his book highlights not only the important role of coenzyme Q10 and hawthorn, but he also spends some time explaining the value of things like L-carnitine and L-taurine and D-ribose, and I'm going to cover these with you as well in this section of the course, which is going to come up very shortly. So when we come back, we'll pick up the discussion with hawthorn, which is a really synergistic nutrient that you use with coenzyme Q10 in many cases to enhance energy production, especially in the heart muscle, and also to help lower blood pressure as well. So we'll come back and we'll take a look at hawthorn.